Hello, everyone, and welcome to our webinar this evening. I'm Cassandra Haddad, and I'm just going to go ahead and pop my slides up here. So tonight we will have an introduction to the clinical guidance for those at risk of genetic ALS and FTD. And this webinar couldn't be brought to us without many people. So first I'll start with our organization and the legacy. So we are a community-led nonprofit. We're affiliated with the ALS Hope Foundation with Dr. Terry Heiman-Patterson. And we're focused on providing education and support resources to our community, promoting research about our community, and advocating for all of those at risk. I'd like to acknowledge our speakers, Dr. Benatar and Dr. Terry Heiman-Patterson, funders and attendees of the 2023 Guidance Workshop, which is what we'll be talking about this evening, everybody who contributed to this incredible groundbreaking paper, all of those who participated in research and the researchers themselves. Without research, we wouldn't have the information to start talking about this guidance paper. And of course, thank you to our educational sponsor, Biogen. So as I mentioned earlier, I'm Cassandra Haddad. I'm Vice Chair of End the Legacy. I'm also a nurse practitioner. I've been a caregiver for a loved one with ALS, and I'm a passionate advocate. I joined the End the Legacy team in honor of the many lost in my family to ALS, for myself who's at risk, and to safeguard the future of my children and many of your children's out there. This evening with us, we have Dr. Terry Heiman-Patterson. She's a professor of neurology at Temple University and the director of the Temple MDS ALS Center of Hope. And she's the co-lead author of the guidance paper, as well as Dr. Michael Benatar, who's a professor of neurology at the University of Miami and the executive director of the ALS Center at the University of Miami, and also a co-lead author of the guidance paper. And I'm going to stop sharing my screen now, and I'll turn our evening's talk over to Dr. Benatar.
Great. Thank you, Cassandra. Great to be with you all. And thank you for organizing this. Can you just tell me you're seeing the slideshow? Looks good?
Yeah.
Okay. Great. So thank you again, and thanks, Terry. This has been a great partnership in putting this together with all of our colleagues. And I think what we're going to do is I'm going to try to give a high-level summary of the guidance and what's in it. And then unfortunately, I have to dash for a prior commitment, and Dr. Heiman-Patterson is going to take the difficult task of answering your questions. So thank you, Terry. I have put up a QR code here, which should give you a direct link to the paper, which is open access, so there should be no difficulty accessing it. Okay, so by way of introduction, I think you know this, that the impetus for this came from the carrier community, who had really encouraged, maybe insisted, that we develop a best care framework for providing clinical care. And the questions really were that, or the express need was that we provide guidance on clinical monitoring, and what some of the legal concerns are that are faced by the carrier community in thinking about seeking care, and which putative environmental factors should be sought out or avoided. And this was a workshop really led by Dr. Heiman-Patterson and the ALS Hope Foundation and End the Legacy putting this together, organized in Pennsylvania in September of 2023. And this brought together a diverse set of stakeholders from the community, people living with a pathogenic variant at risk for disease, patient advocacy groups, a range of clinicians, neurologists, neuropsychologists, psychiatrists, all involved in the care of people with ALS and FTD. Also genetic counselors, ethicists, statisticians, epidemiologists, nurses, and representatives from the pharmaceutical industry who focused on drug development. And here are the questions that we asked the attendees to consider. We wanted to understand predictive genetic counseling and testing, including the socio-legal implications and what recommendations we could make about approaching these issues. What would be the appropriate use of therapeutic agents that have been approved by regulatory authorities for people who have clinically manifest disease, and what recommendations could we make for the carrier community? Are there any recommendations regarding lifestyle, occupational and environmental exposures, physical exercise, smoking, nutrition, management of hyperlipidemia? as well as the nature of clinical care and the frequency of evaluations. And I think we tried to stay true to these topics, but I think we also spread out a little bit as the conversation took us. In general, I should say, and I want to underscore this, that we recognize that depending on the pathogenic variant that people are carrying, you can be at risk for ALS, for FTD, or for both. And in general, we found that we have more data in the ALS world than we do in the FTD world. And we've tried to highlight where those discordances exist, but also to learn from one field to the other in trying to think about how to guide best practice recommendations. So a word then about genetic testing and considerations before we come to the recommendations. The first is to say when one's approaching this issue, this begins really with pedigree construction, so drawing out a family tree. This gives us lots of information. It tells us something about penetrance, the proportion of people who likely carry a gene who develop the disease. It tells us something if we're starting with testing an affected individual who might be informed in the family of those results, and also to begin to think about a plan for communication of those results. We underscored the importance of a comprehensive genetic evaluation of an affected individual as a starting point. And there are two things that I said there. The one is starting with an affected individual, and the other is that we should look broadly for the full array of genetic variants that we know can be associated with this group of diseases. And importantly, because sometimes there may be more than one gene that's implicated, so we should think broadly. We should discuss this plan for communication because predictive testing or identifying carriers begins with communicating that information from an affected individual to other family members. And recognizing that predictive genetic testing is highly personal, to recognize the potential psychosocial, ethical, and legal implications of learning this, documenting this information in a clinical record, to recognize that follow-up needs to be tailored to individual needs, and that referrals as appropriate to other clinical services, to research, to consider alternative reproductive methods, are all things that need to be engaged. And to underscore that throughout all of this, the importance of genetic counseling, which is not a single point in time event, but a process that needs to proceed from a pre-test environment into a post-test environment and support that extends beyond that. So I'm now going to just summarize the recommendations, not so much summarize, but read them to you because the wording is important and I don't want to misstate them. And so we said that for genetic counseling, individuals with a family history of ALS or FTD spectrum disorders who are interested in predictive genetic counseling and testing should first determine whether their affected relatives underwent genetic testing. And ideally, patients with a genetic etiology identified for their ALS or FTD should communicate these results to their relatives, both close and distant, who may be impacted. And this will empower those individuals to then explore whether they want predictive testing. Predictive testing should really only occur in the context of genetic counseling, ideally by a genetic counselor, but if not available, then by another qualified health professional. And this is essential given the emotional and practical considerations that are essential to consider prior to testing. People receiving predictive genetic test results should be referred for follow-up that is tailored to their individual needs. That may include, for example, mental health counseling, subsequent genetic counseling, but also potentially a clinical evaluation. Referral to a genetic counselor with expertise in the reproductive space is essential if a person would like to consider in vitro fertilization or pre-implantation genetic testing or other alternative reproductive methods. And carriers of pathogenic variant at risk for elevated ALS or FTD should be provided with information about available research opportunities. So some of the socio-legal considerations, and this is not my area of expertise, so learning from the lawyers, but I'll just sort of highlight that there are three related but different issues here. One relates to your privacy, and this is that access to an individual's information should be restricted. And there are some legal protections around this. So, for example, the Genetic Non-Discrimination Act, GINA, it specifies that employers cannot ask for genetic information or use it in employment decisions. But related to this is confidentiality that predicts against unlawful disclosure of information. So the Health Information Privacy Law limits disclosure of health information without a person's consent. But there are some important considerations that are new from the 21st Century Cures Act. So, for example, if you're seeking clinical care, medical records will be released to you as they become available, including the results of genetic testing. And so you might see those results before your counselor has had a chance to communicate with you and to prepare you for those. So you need to know that going in terms of when and how information will be disclosed, and work with your genetic counselor or clinician to access and receive that information in a way that's best for you. And then there's the idea of discrimination that limits or prohibits decisions about using using health information. And there are protections through GINA for health insurance, but not for long-term care or for disability insurance. So our specific recommendations with that protections and the limits of these protections that are offered by laws such as GINA and the Affordable Care Act should be discussed early and really before this information is documented in the medical record. Because once it's in the medical record, it can't be taken out. And so we should know what those implications are before it's documented. And patient access to their medical record should be factored into decisions about what to document, and plans should be made for review of any genetic test results. And I've highlighted this issue already. So let's move on then and talk about approved therapies and some of the considerations before I come to our recommendations. And to say that we have some approved therapies by regulatory authorities in the ALS space, regrettably, we don't yet have those in the FTD space. So in the ALS space, we have riluzole, we have edaravone, and we have tofersen, at least for people with clinically manifest disease. The FUS ASO is in clinical trials, so we've listed it here, and it came up in discussion, but it's obviously not yet approved by the regulatory authorities. So for riluzole, there really is no evidence for efficacy in people at risk, so in pre-symptomatic carriers. And there was some discussion that the evidence, riluzole, the way it works is by dampening down cortical hyperexcitability, neurons that are irritable and overfiring. And there's evidence for early cortical hyperexcitability, but the effects of riluzole are short-lived. And so we didn't even have a strong biological case to be made for how or why this might be helpful in a pre-symptomatic carrier. For edaravone, again, we have no evidence of efficacy in carriers, and there's no biomarker evidence that the processes, the oxidative stress mechanisms targeted by edaravone are relevant in the pre-symptomatic space. And then for tofersen, there's an ongoing clinical trial. The same is true for FUS carriers. And just to say that for both SOD and FUS carriers, penetrance is incomplete. We have limited biomarkers to predict the timing of developing manifest disease, and there is potential for serious side effects from these agents. So based on this, the recommendations for these FDA-approved therapies was as follows. As there have been no studies of the efficacy of riluzole or edaravone in unaffected individuals at genetic risk for ALS and FTD, and only limited evidence that the biological mechanisms targeted by these agents are active during the pre-symptomatic stage, we recommend against the use of these agents in unaffected carriers. We said as there is good a priori biological rationale for believing that therapeutic interventions are more likely to be effective when initiated early, we do recommend the initiation of these approved therapies as early as possible following phenoconversion to clinically manifest ALS. That will underscore the importance of close monitoring and follow-up to make sure that we can initiate these as early as possible. And for these gene targeting therapies like the ASOs, we said outside of ongoing clinical trials or new evidence of efficacy, we do not recommend their use in unaffected carriers, especially when the toxicity of long-term administration of these agents is unknown. So how about some lifestyle considerations? So I'll try to summarize a few things here, just I guess with some graphics. So there's this observation that's been made that we don't fully understand, that people have a higher body mass index, they have a reduced risk of ALS. There's also been an observation that amongst carriers of a C9orf72 repeat expansion, they have a lower body mass index. We'll come to how we interpret or make a recommendation from that in a moment. I guess related to considerations about body mass index and metabolic syndrome more broadly, there's a little bit of information about cholesterol, but it's also conflicting. And so there's some evidence that higher LDL, that's the bad cholesterol, might predispose to an increased risk of ALS. And actually for HDL, it's unclear. There's some conflicting information, with some suggesting an increased risk, some a reduced risk. I think the best thing we can say is that lipid profiles seem to differ in people at risk for ALS before it develops, but we don't yet really know whether this is causally related to the development of disease and how that should or should not guide a behavioral intervention. This brought up the question of statin use as a cholesterol treatment, and really the evidence here is inconsistent and didn't enable us to make a recommendation. We did discuss some other considerations around diet and nutritional supplements. And there was evidence that increased intake of these things called polyunsaturated fatty acids, or PUFAs, especially alpha-linoleic acid, may lower the risk of ALS. We spoke about smoking, and there's evidence that smoking has no protective effect on the risk of sporadic ALS or on C9 ALS or FTD. And then lots of discussion around exercise. And to say the evidence in the ALS and the FTD communities may pull in slightly different directions here, but I think they're both very inconclusive. For FTD, physical activity may be associated with slower decline of disease, and that's amongst people who already have FTD. In ALS, I think for professional sports, those who play soccer, rugby, American football, specifically those sports, there may be a higher risk of ALS. But in general, for ALS, there's some evidence that exercise may be protective. So you can hear there's a nuanced message here, and one that needs to be tailored to individual people. What about occupational and environmental exposures? So there is some potential harmful effects of occupational exposure to very high electromagnetic fields and agricultural pesticides. We had a lot of discussion about selenium, and again, not my area of expertise, but this comes in two flavors, the inorganic flavor and the organic flavor. It's the organic form that's mostly in food, but it's the inorganic form that can be found in drinking water, but most of the exposure is occupational. And this is the form that may yield potentially harmful effects of excess exposure. We discussed military service. There is an increased risk of ALS amongst those who've served in the military, but there's also no evidence that avoidance prevents onset, and certainly no evidence in a genetically at-risk population. So these then are the recommendations that we made. So with regard to these omega fatty acids, we recommend that ensuring adequate intake of omega-3 fatty acids, and particularly alpha-linoleic acid. And just some notes here that in general, there's some preclinical and clinical evidence that consumption of foods that are high in these is associated with a lower risk of ALS. And it's likely safe when used in amounts that are found in foods, but we don't have information about the safety of higher doses. So we're not recommending excess supplementation. And then just listing some of the foods here that are high or rich sources of this nutrient. We did discuss caffeine intake. We didn't recommend any modification. There's no evidence that caffeine intake has any causal relationship to ALS FTD. For those who know me, I love my coffee, so this is a good recommendation. I don't have to cut back. Selenium, we said consume no more than the daily recommended intake. And I've drawn your attention here to the distinction between the organic and the inorganic forms. For statin use, we said use as clinically appropriate. There's no direct evidence that they have causal impact on ALS and FTD, and they have other health benefits, so no recommendation around a change. For other metabolic interventions, we said use as clinically appropriate. We've discussed some of this lipid divergence, but there's no evidence that dietary or non-statin pharmacological intervention for metabolic disease can impact the risk of ALS or FTD. So again, general health recommendations for cardiovascular and cerebrovascular health. For smoking, the short answer is don't smoke. I don't think I need to say that with any more nuance. Exercise. We recommended following the WHO guidelines for sufficient exercise and to say there's no conclusive evidence that non-professional exercise impacts the risk of ALS or FTD, and certainly exercise may have physical and mental health benefits. I didn't talk about head trauma earlier. We recommended to minimize it. As a neurologist, that's generally good advice. We think with our heads. We don't like to hit things with them. But the evidence linking head injury to ALS is inconclusive. But there's a broad recommendation based on the association between head trauma and chronic traumatic encephalopathy that we should minimize this risk. And then in terms of the occupational and environmental exposures, we suggest to consider minimizing occupational environmental exposures to fertilizers and pesticides, as well as lead. And we recognize this is a good generic sort of guidance, but it may be hard to implement. And just to say that there's no direct evidence that these environmental exposures impact the risk or age of onset in people at genetic risk for ALS. I'm moving quickly, but just to say we are drawing inferences from often population-based studies and people who may have gone on to develop non-genetic ALS to try to develop a framework for thinking about guidance for carriers. But most often we lack specific information in a carrier community to know how these recommendations can impact risk. So very quickly, some clinical care considerations. And so I've divided these into an initial evaluation and then follow-up. So that initial consultation, care should begin with informed consent. What are the risks of medical record documentation? What are the risks around predictive genetic testing and the socio-legal implications of documenting this information? It's important to appraise the availability of support systems and people's individual need for counseling. That initial assessment should look at motor function, history of symptoms, clinical examination, EMG, but certainly for carriers at risk for FTD as well, a cognitive and behavioral assessment. And this requires a formal assessment, as well as, if the carrier is willing, input from a loved one is helpful, but obviously only with the consent of the individual. In follow-up, we think the frequency depends on many things: your age, what the particular genetic risk factor is, what the findings were from a prior assessment. Were they completely clean, normal? Were there any signs or symptoms of concern? And what are the clinical needs? What are the perceived needs that you have in terms of your clinical care needs? What has been the interval history of symptoms? How have things changed since that initial assessment? And then to have a discussion about the return of results of the clinical assessment. So what do people want to know? Do they want to know if there's signs of ALS? Do they want to know if you find something else that's incidental or maybe unrelated? Have those discussions with your clinicians that they can share with you what it is you want to know and are ready to know, and then document the consent regarding this disclosure of these potential findings. There should be consideration around relevant biomarkers. Neurofilament is one. It's an imperfect tool. We know it best in the research setting. Depending on age and potential relevance of an Alzheimer's disease phenotype in an older population, to think about Alzheimer's disease biomarkers that are already in clinical practice, if these are relevant. So the recommendations then were for clinical evaluation of individuals at genetic risk for ALS or FTD should include a history of symptoms, if any, an assessment of what information the individual would like returned from their clinical evaluation, and consent regarding disclosure of potential findings, as well as a motor evaluation and an assessment of cognitive, language, behavioral, and neuropsychiatric symptoms. Unaffected carriers should be informed that input from a loved one is helpful in assessing possible symptoms of FTD, but that the impact on relationships of a loved one serving in this capacity is unknown. And as such, an informant report should only be sought with the explicit consent of the person at elevated genetic risk. And the frequency of evaluation should be tailored to an individual's age, the genotype, any prodromal manifestations of disease, their personal preferences, and their clinical needs. And so before I turn over to Dr. Heiman-Patterson, just some acknowledgements. Firstly, to acknowledge Terry. This is really a joint effort, us together, but with a host of colleagues from the community, all of the attendees at the workshop, as well as all of the sponsors for the workshop whom we've listed here to acknowledge their support, for which we're very grateful. So I'm going to stop there, Terry, and turn over to you.
Thanks so much, Michael, for doing all the work of summarizing uh, the guidance. And so, I think Cassandra and I will take it from here. Cassandra, if you want to unmute.
Sure. Thank you so much, Dr. Benatar. I know he has to run for a conflict, but I just think this is really exciting that this is the first time I think we're talking about the webinar really to the community at large. And although it doesn't seem like there's a ton of like, okay, I'm going to do this, 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 and this really was the first time that the stakeholders had sat down and said, what evidence do we have? What advice can we give people that is sound and grounded in science? But this is also a really hard area to study because to try and figure out if something is preventing conversion is a little bit tricky. So let's just talk a little bit, Dr. Terry, about what does the landscape look like right now in genetic testing?
Yeah, so, actually in preparation for this, workshop, I had sent out to my colleagues, I wanted to know several things. Okay, who's sort of offering genetic testing to individuals already affected and their family members if a genetic abnormality was found? And if they found someone who was asymptomatic or, not manifesting any disease, but a carrier, an at-risk person, what were they doing? How were they following them? And if they were assessing them, what were they doing to assess them and how were they following, and who would give treatment? Who would use any of the treatments in an individual who was at risk but not manifesting any phenotype, which what we mean by phenotype for, I know most of you on the webinar know what that means, but for those who don't, phenotype means evidence that the disease is actually manifest or active. And so, I had 71 of my colleagues, from different ALS centers across the Northeast ALS Consortium who responded. And so, and luckily 90% were actually offering genetic testing to all people with ALS. So when somebody came into their office and had ALS, they would genetically test them. And then if they ended up being positive, they would then discuss it, with them that other family members might be at risk. There were, however, 10% who would only test people if they had a family history. But we know that a certain portion of people without a family history actually carry these genes, which speaks to that uncertainty of penetrance, right? So you can carry the gene and not have the disease or not manifest disease. And even in the same family, you can have two siblings, for instance, who carry the SOD1 gene, and one person gets, disease or manifests it while another family member does not. And so, the factors that determine the penetrance and whether you're going to manifest are really important. And I have to spend some time talking about that because that's my research, which is genetic modifiers of ALS and things that modify, if you carry a gene, what determines if you're going to have penetrance or actually have disease if you carry the gene. So 9% would only test people if they had a family history. And it turns out that most people don't follow folks. If they identify somebody who is not manifesting disease, but is a carrier, they really don't follow it. And like over 60% of the ALS clinicians had less than 10 people that they were following who were at risk and didn't have disease, suggesting there's a limited experience and not a lot of folks being followed so that we can do research into the best ways to follow. When I do clinical research and I say, what's the best, way to follow folks, how frequently, all the things that Dr. Benatar was mentioning. How frequently should somebody be seen? What should they get as baseline? How often should you do an EMG, a neurofilament? these biomarkers of disease or evidence of nerve damage. It means we don't have a lot. And when asked, when would you evaluate somebody who was a gene carrier, a third said, oh, only when they have symptoms. So that, and 2/3 would follow them up, but they recommended, the vast majority said they'd follow once a year. And then the question was, what would you do, right? How would you, where would you start? And 70% of folks would do an EMG, but only if they were symptomatic. In other words, wouldn't get a baseline. About 50% would do the NFL, and they would do that initially and then follow it at some irregular, no consistent 6 to 12 months. And about 60% recommended that cognitive testing and recommended that be done every 1 to 2 years. Now, what about treatment? So that's the situation with follow-up. No real guidance, right? No real consistency in our community. And then finally, treatment. I mean, 60% wouldn't do anything. 13% would give Rhizol, 5% Edaravone. And, for folks with SOD1, tofersen is the approved drug for SOD1. There would be 48% of folks would at least talk to their at-risk individuals about it, and offer it. 23% only if there was an abnormal EMG, and 17%, around 20%, only if the neurofilament was up. So, and we're talking about people who don't have any other manifestations. So, they're normal clinically if you just examine them. And there was one physician who, no matter what, totally normal with everything, would start based on the idea that they carry the gene and at some point might manifest, but we don't know that, right? That's the problem with designing at-risk clinics, is we don't know the answers to this. But if we don't start thinking about it and initiating clinics that follow on a regular basis the at-risk community, will never get anywhere.
Dr. Terry, there's so many great things to unpack there. And I think I just want to highlight a couple of them. One is, we're talking about clinical monitoring. We're not talking about research.
Correct.
Yes, we're happy to connect people, but we're talking about individualized clinical monitoring. And that's why Dr. Benatar talked about, getting permission to put this into people's medical records, because once it's in there, it can't come out. The kind of cat's out of the bag, or as we would say in Lancaster County, the horse is out of the barn. But to do this big,
on fire, I might add.
yeah, the big pivotal shift in thinking from going from just following people from a research model to actually following them clinically is a huge paradigm shift. And so I really hope the community understands that this white paper, although limited with the amount of recommendations, was really groundbreaking, because the biggest question kind of we have as a community is, why hasn't this been done before? Right? Where have been these guidelines? And there's just not a lot of information. So I was thrilled to have both you and Dr. Benatar, because this is really a pioneering moment in the genetic community. So I'd love to hear more about trying to design genetic clinics, how to get genetic clinics uptake both in the care provider community, and how do we get the community to be involved in care and recognize the value of care? What is the value of care?
So you talk about, I gave you a lot to unpack. So, I'll start with, I think that the paper and our discussion in our community, both Dr. Benatar and myself have been talking about this, and all of a sudden people are starting to say, I'd like to think about how to do an at-risk clinic. And that we've already started one. And so I think that's the first step, is having an interest. And we're all going to do it. While we'll take that guidance, I think we're all going to have some differences in the way we do things. But it's an important start, and it's going to be a stepping stone to the next workshop that Dr. Benatar and I are thinking about, which is to really get people who are following folks clinically in these types of at-risk clinic together to get a baseline. It will not be this is a draft. It's not the final blueprint. It's a draft. Let's get a starting point. And so in our own at-risk clinic, Cassandra is the nurse practitioner in my clinic. So of course, she knows this. Our first steps are our kind of, okay, got to have a starting point. I could go around and around in a circle forever trying to decide the best way. You just have to jump in and start, and it'll be a work in progress. But it's okay. The first thing is, as Michael points out, you have to get a good genetic counselor, and you have to have a discussion about what it means. What do you want in the record? What diagnosis should we use? And we've been using things like family history of ALS or at risk, but that's one question that the community has to answer. How do we do this so if records are accessed, it doesn't impact ability to get insurance and other issues in a person's life? Once people are in your clinic, okay, so now we got past that, we've got the genetic testing, then we start with assessing a couple of things. I want a baseline, and whatever you do for that baseline, where is the disease now? Is it manifested at all? Or are we totally asymptomatic and just at risk? And we don't know if you're at risk and normal. We don't know if you're ever going to manifest. The penetrance is a moving target. A while ago, we thought that, for instance, with C9, the penetrance was quite high, but we have evidence that it really isn't as high as we initially thought. And for other gene mutations, I'm sure we're going to find the same thing. But where is the person right now? And to do that, I do a good exam, I do a baseline EMG, and I do a neurofilament light chain. The second thing I have to assess is, okay, and all of that's normal, and I see no evidence on my exam of any concern. The next thing I have to do is, what about where is this person emotionally? And that's going to determine if somebody's really anxious. I'm going to see them much more frequently than if they're not, right? In addition, the other things we have to take into consideration in terms of timing are some things Cassandra actually has been helping me put together, which is what we do know about the different mutations and when they tend to surface, what the average age of onset is and the penetrance, so that we can plan. If somebody's 20 and the average age of onset is 60, am I going to see them every year until they're 60? No, I'm not, because I'll be retired, but because I'm a little old right now. But what is that, rate going to be? And so some of the sort of decision making will be determined by that. But that would be another thing we'll take into consideration. And then Cassandra and I want to go over these recommendations, because if people aren't aware of them, we'll go over them. And what we hope is that in the next iteration, we'll have more recommendations. We'll be able to give more information. But you know what? The only way we're going to do that is to build an infrastructure of clinics that care for people at risk so that we can collect this kind of information and also provide the support and care that people need. And, good clinical care and excellence in clinical care, I know for people living with ALS, as well as people living at risk, I think isn't only care, but it's also clinical research so that the next generation has better care and so that we can do more. So that clinical research is important. And we're really sort of a foundation for the research that's been going on, but now it's time to take care of folks and be a place where they can come and we understand. And so, that's sort of our goal in the clinic. And my hope is that it spreads and that, we have 10 and then 20 and then 30 clinics. One of the concerns, of course, by my colleagues is, if we do this, there aren't enough clinics to handle all the at-risk individuals, because when you think about it, the numbers of at-risk is so much greater than the 20 to 30,000 people affected with ALS in the country. But you know what? the follow-up is less, less frequent and, less intensive than, an ALS multidisciplinary clinic. It's sort of semi-multidisciplinary. And I think that we can handle it if done in the right way and integrated properly.
Absolutely. I think being really mindful about how we're setting these clinics up and really trying to come up with a gold standard of care. So many disease processes have a gold standard of care, and oftentimes reimbursement is tied back to that standard of care, such as an epilepsy. So, my kind of lifelong ambition is really to get a good quality, evidence-based gold standard of care for people at risk, and then we can roll that out across the country. We have finite resources. So I think everybody's in agreement. We don't want to keep reinventing the wheel. So Dr. Terry had mentioned we're kind of working on a little bit of a formula to try and figure out a little bit and distribute it of when people should be seen while still practicing with this precision medicine approach of, sure, we can say in general what a gene looks like. What does that gene look like for your family? Because for some of the genetic mutations that matters, and what does care look like for you? Because that's really what's most important. At the end of the day, is that person sitting in front of you. And as someone at genetic risk, we all have the same question is, when and if is this going to impact me? And right now we don't have an answer for that. So absolutely, why we have you there and we're doing your one-on-one care, we want to not just involve you, but your other possibly affected family members in research so that we can build something to answer that question. Yeah,
Yeah, we have some questions in the chat, Cassandra, if you want to.
I would love to bop over to those. So I did see there's one about neurofilament chains in
GFAP,
GFAP. Yeah, I don't know that one. So go ahead.
glial fibrillary acidic protein. NFL is now available in a clinical lab. LabCorp does NFL light chain. So, clinicians can order it. I don't believe GFAP is commercially available, and Jean has some comments on that.
Oh, I think she might just be hitting the button.
Oh,
I will also say that in terms of NFL, you do have to be very cautious. So when you run NFL through LabCorp, it is not the same NFL cutoff or reference range that's
sensitivity.
run for clinical research. So you have to be very careful. They're not apples to apples. Even though LabCorp is running, like, for example, Atlas's NFLs, they're using a different assay. So this is another importance of why we should have a care partner for you, because otherwise sometimes you're left trying to run your own numbers and figure them out on your own, which is really tricky. So although NFL is available commercially, please partner with someone to help you figure out what does it mean.
Yeah, and done in the same lab, like clinically, we would be. I do it in my research lab, but
Yeah.
I send my clinical stuff to LabCorp as a CLIA lab.
Yeah.
You know.
And I'll just hop down. Amy has two great questions. So how can you become a patient at the at-risk clinic? Right now, we're having our clinic nurse, Mary, kind of speak to everybody ahead of time and see, have they seen a genetic counselor yet? Do they need referred to a genetic counselor? And to tell people like, hey, once you come into clinic, this is in your medical record. So let's talk about that before that happens. And then the question is, how many EMGs do I need to undergo? That completely resonates with me. I stopped counting at 10, I think. I've had a lot of EMGs and they never get less painful, no matter how talented the person you're doing is. The tricky part is research sites are beholden to the research protocol, and that's what they're following. So they're trying to answer a research question. And although they do provide a lot of support services, they're not really responsible to just you as your provider when you're in that relationship. It's a different level of care. I would love if they could share their information, but research clinics don't usually share their information either back to the participants or to other providers officially. Sometimes unofficially, they'll talk to each other, which is really helpful. And for a lot of us, we are involved in several research studies. I'm one of the people who are involved in both an at-risk care, not just as a provider, but I go to an at-risk center and I'm involved in research. I think a lot of it too depends on your research site. So I've recently changed up some of my research sites because some of them are much more responsive than others. And when you have a concern right now. And you need to talk to someone about that concern right now. We can't wait weeks to investigate concerns if we're concerned that we're manifesting. So I don't know, Dr. Terry, if you had any.
Yeah, well, I was just going to say that, and your at-risk clinic, which has a different bend, it's really to take care of you. We have to be responsive, and that's why we all talked about, what is your, infrastructure emotionally about all of this. And I'll comment that some of the research sites are interested in also developing a parallel at-risk clinic, but it wouldn't be done under the same sort of umbrella, in the sense that you wouldn't get both visits you might get both visits in the same day, but they wouldn't be by the same team necessarily. And how many EMGs do you get? Well, Cassandra's had 10, but they've been in the context of research. In the context of a clinical follow-up, and this is one of the differences, you're going to get, for me, I'm going to get a baseline. I'm definitely going to get another one if I see anything or you have a concern or I have a concern that something's going on. Otherwise, it might be very long between EMGs. If you have no symptoms and I don't see anything, it might be once every 5 years or once every 10 years, but so it's sort of different how often you get it. And, research centers don't feel necessarily like and you can talk about which research centers you feel are more responsive, but for research centers, they're not, they're not your day-to-day care, so they don't necessarily feel responsible as a physician as I might feel to respond to a call same day because I'm taking care of you and you're having a problem. So it's a different mindset. You're muted, Cassandra.
Sorry, I was coughing. Research sites are often limited by finances and staffing as well. So this isn't meant to be a criticism of research. It's just kind of two different areas. As far as which research centers are most responsive, particularly for FTD, FTD is not my specific wheelhouse. So I can't answer that because I have no experience as a research participant in FTD. Certainly we can get some of that information for you if you send an email to and the legacy. Just check us out on our website. We can connect you with FTD resources. And I think a lot of it's going to depend on your site because there's some big research studies that have multiple sites. So it might be, was it closer to their staffing patterns, or how did that email get handled, or who did it go to? Was your investigator out of the country? All these things can kind of impact how responsive research sites are and what they're responsive to. I think the great thing is when you develop a really good relationship with a researcher and some care providers that you do end up hopefully getting some good feedback quickly. And thank you, Jean, for dropping the link in the chat to recruiting studies. That's something that we want to do in at-risk clinics, and on behalf of End the Legacy is connect people who are interested in research to those resources. Dr. Terry, I haven't come across anything about alcohol and FTD ALS risk.
Yeah.
I will say all of the latest research on alcohol is really bad in terms of heart disease, in terms of mental health, in terms of cancer. Really, cancer world is saying like 0 amount is safe. I talk about this as a family practice.
If you're worried about head trauma and ALS, drink it. I just looked at somebody's chart who I'm supposed to see tomorrow, and they've had 3 admissions in the last 6 months for falling down drunk, literally causing an intracerebral hemorrhage one time and orbital fracture another time. I'm not making this up. So yeah, it's
Was this after the Super Bowl?
No, it wasn't actually. But it's like smoking. In what world would you ever recommend smoking? In what world could you ever think alcohol would be good for anything? But there's not much literature on it. And I see also a question, Cassandra, about why not riluzole? And I think what we saw was that there was a spectrum. We couldn't come out and say, yeah, you should, and there's no evidence that you should start riluzole, in at-risk folks. I think you have to weigh the adverse events, which is, liver dysfunction, sedation, um, against the potential good. And the problem is there's no evidence that it would slow down, although, when one thinks about it, hey, it looks like it slows disease down, and you want to start things that slow disease down as early as possible, and why not start it pre-symptomatically? Dr. Benatar talked about there's, the way riluzole works, one of the mechanisms is this hyperexcitability. Another mechanism is glutamate excitotoxicity. And there's no necessary evidence that those are active mechanisms pre-onset, if you will. And so I think that's going to be very individual, clinician to clinician, as to whether or not they would start it. And I think it's the kind of conversation you could have if you go to an at-risk clinic with the clinician running it, and they're going to feel differently about it. Now, something like tofersen, you have to understand, tofersen does have some, first of all, it means lumbar punctures every month. And if you're not having any symptoms, I don't know if you necessarily want that. The second thing is that while it's not common or frequent, you can get an inflammation of the nerve roots that's quite painful, that occurred in some folks getting tofersen. It's called an arachnoiditis. And so, might not have as much enthusiasm for starting that on somebody who has no symptoms. But that's what the ATLAS trial is really about, to institute it at the earliest possible evidence of disease, which is a bump up in neurofilament light chain, which precedes symptoms, but suggests that onset is going to occur. And so that's why research is important. How can we identify, get good evidence of when to start these drugs?
Yeah, and I really love, driving precision, and Dr. Benatar is doing a lot of work on this kind of mild motor impairment, and really looking at this as a spectrum and not as a light switch on and off, which was mentioned in one of the comments earlier. So I really think it makes sense to think about things mechanistically. How does this drug work? How does it prevent? And does that impact your specific gene, right? Because it's such a homogeneous disease. As far as for Gary, the alpha linoleic acid, I actually run a ton of omega panels as part of what I do, not with Dr. Terry, but in my regular 9 to 5. And it is rare that I see someone who has sufficient omega-3s and is not high in omega-6s. So certainly I love to talk about supplements, and we are looking to host a webinar soon talking about supplements with the lovely Dr. Bedlack, who I just appreciate and admire so much. So there wasn't strong enough evidence to recommend ALA supplementation, but what I would say is, just for seeing the average population's omega-3 and 6 panels, you've got to get your seed oils out, and you've got to get those avocados in. So I think all of us could really work on increasing PUFAs in our diet, because there's many, many, many health benefits. And one of my favorite things to say is, the highest risk for everybody in the whole wide world, all men, all women, is heart disease. So live a really heart healthy life, including those PUFAs in there.
I'd like to add that there is evidence that it slows disease down. ALS, as well as other neurodegenerative diseases, suggest the commonality or overlap in mechanisms. And we're actually going to be looking at that using, remote monitoring of diet. We've got a dietary app we're working up to look at the dietary inflammatory index, which is driven by omega-3s. In other words, high omega-3, less inflammatory index. And remember, these work by reducing oxidative stress. Oxidative stress drives neuroinflammation. Neuroinflammation probably drives disease. And so by reducing your dietary inflammatory index through the use of omega-3s and Mediterranean diet, we're hoping to show that we can slow progression of ALS down. And I'd like to do a similar study in the pre-symptomatic folks to see if that just is such a long study. That's why we have to find ways to ask these questions in at-risk carriers.
and ways to fund amazing research like that. I'm really excited. Dr. Terry is, I think, one of the few people really looking at what happens if you put people on anti-inflammatory diets. So some of these things just kind of make sense, but I'm really excited to explore them more. I haven't heard anything about Biogen's new drug, and I think that might be like a little bit outside of the scope, but certainly if we hear things, we try and get the word out. Same thing for C9 gene therapy. I don't know that that's necessarily within the scope of this webinar, but I appreciate the question and we'll try and get more information out on that as well. Anything else we can answer about the clinical guidance or the startup of these at-risk clinics? And certainly if you didn't have time to get your question into the chat, feel free to drop them through email to our website. This will not be the last we hear on this topic. I'm really looking forward to having the next workshop. I'm hoping maybe it's this year. We'll see what happens with that. Dr. Terry, any ideas when the next workshop's going to be?
No, we're putting together what the program's going to be. I would imagine, these take a while to put together because we had international colleagues.
Did.
And by the way, if you could put a number in for Amy, she was asking for
Yeah.
Mary's number. So, but these take a while to put together. But I would imagine, sometime in the next about 9 months to 12 months from now. We may want to move it to the spring to avoid the winter weather here in Philadelphia.
But do keep an eye out. And the Legacy is having their second annual in-person meeting in Philadelphia. That's what reminded me to say it, in June. So check out our website. The dates and how to RSVP are on there. It'll be several days of amazing information just like this and moving our community forward. So thank you so much again to both Dr. Terry Heiman-Patterson and Dr. Benatar for being present with us this evening, for sharing your information with us, and most importantly, for getting this workshop off the ground so that we can move this community forward. And if you are looking for our website, if you want to stay informed on webinars like this or what is moving and shaking in the community, here's a QR code. And also please be sure to follow us on social media. Drop us messages on there or on the website. We're happy to stay in touch and to distribute more of this great information. And any closing words from you, Dr. Heiman-Patterson?
No, I appreciate everybody's interest. And we need, if we're going to make headway, we need the community to help us and help us in, helping us to develop the clinic systems and figure out how to do this right, make a difference, and also participate in clinical research and research with treatments. So,
Great.
You can make all the difference.
And keep an eye out, friends. There will be a survey coming out from End the Legacy where we're going to do a temperature check and see what people's thoughts are on the clinical care guidelines in terms of how willing they are to be involved in care and what they think that care could look like. So we will be surveying the community, and we're really excited to launch that survey soon. Well, thank you, everybody. We're coming up on the hour. Thank you for your time and your attention, and we look forward to seeing you all again soon.